Okay, middle stages of Alzheimer's. Continued memory lapses. Now when you get into the middle stages, you're getting forgetful about your personal history, difficulty in recognizing friends and family, disoriented time and space. The caregiver now is stepping in automatically. Okay? Now you're going to get frustrated because you're playing the game of cards. You can't win anymore. So you're finding you don't go out with your buddies to play golf because you can't hit the ball. And your circle of friends now are going to become narrower. The spouse is still trying to push you out and engage you, but now you're getting resistance because you know something is wrong. Forgetfulness, personal history, disoriented space and time, mood and emotions, personality changes, mood shifts. Okay, all good stuff. Right, so the person is getting more frustrated here, and this is getting to the point where the caregiver stress meter is starting to go up. In fact, this could be the break point for some caregivers. Some caregivers now are saying, gee, you know, I just can't cope. The daughter comes down from Toronto. When she went away last year, Dad was a little bit forgetful, but now, boy, this is not good. So she comes into the doctor's office wanting Dad to be fixed. And that's going to be alarming. So that's when I call up Shirley Lucas at the Alzheimer's Society and say, Shirley, hello. And she saves me about 5 hours of counseling. Basically, people who are away from somebody with dementia for a long period of time see the big changes, whereas the person living with them only see the inexorably slow decline. Right? Okay, so physical abilities, assistance with daily tasks, disrupt the sleep patterns. And that's interesting because they tend to sundown. People with dementia, in the evening you lose your visual reference points. So when you lose your visual reference points, guess what happens to your fog? It gets worse. In fact, it's like driving in the fog. It's hard for us to drive in the fog, isn't it? So if you've got your visual reference points distorted, it's harder for you to comprehend where you are. And that's what happens to people with dementia. And in the evening, that's a real problem because your hormonal shifts are involved with this. You've got less stimuli, and yet you're still probably not wanting to go to bed yet, and you're getting agitated because you know there's something wrong, but you don't know what it is, so it must be somebody else because we think that way. So appetite changes, fluctuates, land use difficulties, visual spatial problems, falls. You know, you get a person like this that falls and then ends up in the hospital with hip fracture, guess what happens? They go into surgery and they come out and they're delirious. Yeah. And they come out of surgery and they're not doing well at all because now their dementia is not following the normal route. It's jumped down 2 or 3 stages. And then the staff see them, well, he can't go home. You've got to go to a nursing home. Well, I don't like that plan. I think a lot of these people who go to the nursing home shouldn't have gone there in the first place. If they had waited and then had the family and supportive structures in place and got them back in their home, they would probably do well in their homes. And we've got to change our thinking in hospitals that the default program is nursing home. The default program is always your home because that's the most familiar environment. And if you've got a delirium or you're confused or you're sick or you're frail, guess who's going to look after your eating best? Your spouse. Your spouse watches you like a hawk. As you know, we got to think about that, right? And you know your environment, see? So now middle stages, behaviors, declining concentration, restlessness, repetitive, delusional hallucinations start coming in. You don't see hallucinations early in dementia. Only in one condition do you see hallucinations early in dementia. And that's in Lewy body dementia. And that's a dementia that's like Parkinson's. These people are really brought out when you give them an antipsychotic because they get the opposite effect with the antipsychotic. They get what? You give an antipsychotic for a person who's agitated, they usually settle down. With Lewy body, they get worse. So that should twig the doctor that, this doesn't fit, there's something here not quite right. And we'll talk about that in a little while as we get out through different stages. Repetition, delusions, hallucinations, aggression, uninhibited behavior, passiveness. So we're getting into the behavioral problems. Now, why do you think we're getting into the behavioral problems? Now, there's a number of theories on that, but Behavioral problems are because the person with dementia is being miscommunicated to. They have lost their sensory stimulus to let them know where they are in time and space. They're interpreting what's coming at them inappropriately. So as a caregiver of somebody with dementia who's getting into behavioral problems, we got to learn how to play neutral. We have to learn to be patient. There's no good telling them, look, honey, you've got to do this way, you've got to do this way. They'll only get more frustrated. You may have to understand that you can't get through to them on this level. You've got to try a new plan. So let's enhance the positives and try to get rid of the negatives. Focus our activities on the functions we can improve. If we got a negative function, go to distraction. Use distraction. Get them off that circuit. Get their brain off that circuit onto a safer circuit. That's the management plan. A lot of the teaching we do around dementia care is based on that. Okay. Mental abilities. Loss of ability to remember, communicate, or function. Guess what? Then you get dysfunction, right? Inability to process information. Severe reading, writing, and speaking difficulties. Severe disorientation. Bad stuff, eh? Mood and emotions. Range of emotions and feelings may become more withdrawn. And then, if you've got a withdrawn patient with dementia and you've got a caregiver that's get burning out, bad scenario. Right? We're losing the battle here because 50% of the care of the person with dementia is caring for the caregiver. We can't care for a person with dementia if we don't take care of the caregiver. They're equally important in this dyad. Okay? And we got a lot of people with dementia, and we're going to get a lot more. 7,500 and growing in 10 years' time will be 15,000. In 10 years' time it will be 22,000. After that, 30 years' time it will probably be 40,000 in this province. Because we got the baby boomers, just by the age demographic, we know that Alzheimer's is going to grow at a phenomenal rate. The fastest growing portion of our population today are not the kiddies. They're 85-year-old plus. And at 85, 1 in 3 people will suffer from dementia. And that's a massive societal problem. So much so a massive problem that the International Alzheimer's Group with the World Health Organization has sounded an alarm in March of 2012 to say that this is the #1 societal health crisis facing our population for the next 30 years. That's amazing. Mm-hmm. Right? That's a very amazing. And for every person who suffers directly from Alzheimer's, there are 2 caregivers that are suffering equally. So we have to realize that this is not just the person with the disease. This is also the person who's helping the person with the disease to cope. So we have a massive societal issue, and hopefully with groups like the Alzheimer's Society and educational stuff, we can now mobilize our community resources to start getting supportive communities. Mm-hmm. If there ever was a time for small rural Newfoundland communities to have a raison d'etre, right? This is the time. This is the time. I can see this being an industry. We can have, in the States now we have communities, dementia communities. We can do it here too. Physical abilities is the late stages. Sleep longer, more often. Now they're getting in bed, so now they're bedridden, so we're talking institutionalization here, and probably appropriately so, but I've had more than my share of patients live out their dementias completely at home with tremendously supportive families. And when the person gets bedridden, in many ways they're easier to manage because they're not wandering. When you put them in bed, you know you can sleep, you know where they are. And we got sensors and stuff and monitors now that we can actually monitor things. The loss of control of bladder and bowel. It never ceases to amaze me. If your daughter is a nurse, they usually can handle this with no problem at all. The hardest part of nursing is seeing their parent, often it's their parent, in the early stages of the disease with the cognitive decline. Because all their lives they've spent looking after bodily functions on the floors. And now, when this happens, it becomes not an issue. It's the cognitive piece that gets them really bad. So you know, what you think logically doesn't sound, actually come out to be logical. Has difficulty eating and swallowing, unable to dress or bathe. Remember I was saying? You're unraveling, unraveling, unraveling. And this is exactly what's happening. And most people in the final stages will die from aspiration pneumonias because they get loss of muscle contraction. And even that sounds bad, it's a great way to die. Because it sounds bad to the caregiver, but it's great for the patient because they go to sleep. Hypoxia, they go to sleep, and it's a very gentle exit from the planet. So if there's one grace, saving grace, if you live out your dementia and the good Lord is good to you, or whatever you believe in, the exit is a gentle exit, usually. 7A's of dementia. Aphasia. This has to do with loss of language. They talk about receptive and expressive aphasia. I can't say things, I can't receive things. So one thing you can say the words, the other one you can't receive, you can't understand what people are saying to you. Or you ask them something and you can't understand what they're saying. Apraxia is the loss of motor skill. They can't carry out a complex motion. Agnosia is the loss of recognition. So I say, what's this here? It's a ruler. Amnesia is loss of memory. If you can say that, good for you. Agnosia. It's loss of knowledge of an illness. Apathy is loss of drive. Altered perception is misinterpretation of sensory information. So again, they talk about the 7A's of dementia, and these are areas of loss. So you don't have to have all of them together, but when you look at it, function is tied into a lot of these. The function is language, motor skills, recognition, loss of memory. You can see how these things would affect your ability to function in society. So you can see how these things could easily affect your independent activities of daily living. And that's when it spills over and the diagnosis is made. Okay?
So Dr. Butler, some of those patients that I see that are in-house patients that, you know, they're diagnosed with Alzheimer's disease, but when you look at all those A's, their language is perfectly there.
Yeah.
They might not be happy.
Right.
And their motor skills, their recognition, like one lady I remember specifically could recognize the doctor that admitted her, and she was so angry, but just him walking down the corridor, she knew exactly that's him. Like how does that happen? How do you?
If we understood how each individual brain was developed, we could probably understand how, when the decline starts, how it comes off. It's never consistent for two people. So some people will have the language more affected than others. Remember I said in primary progressive aphasia, some of those become Alzheimer's downstream. Apraxia, loss of motor skill, that can be, some people are naturally clumsy. Give them the clumsy person with dementia, guess what? They're going to get more clumsy. Loss of recognition, the ability, this is very high order cognitive function. And it depends where the neurofibrillary tangles have interrupted the circuits. And if it hits the circuit that's really a common circuit and does a lot of damage to it, guess what? It comes out. You've got to have a tremendous amount of neural damage in the brain before we can pick up any of these things. 7 years of disease process. You know, it's amazing, really, when you look at how much redundancy this built into our neural networks to maintain. Right? And we've got some of the best people in the world working in this province, in this area. We've got the girl, one of the physios that works at the Miller Center, you're probably aware of, Michelle Plowman, who's a Canadian research scholar, and her area of expertise is neuroplasticity. We're so fortunate to have her stay here in the province. We've got a little research center that we're starting at the Miller Center, so we're going to be looking at this stuff. And how can we, and that has a lot to do with this disorder, because neuroplasticity teaches us how to improve on brains that are damaged. Perfect for us, eh?